Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about a case of scleral fixation IOL and its complication, that is intraocular bleeding. A 76 years old patient with history of diabetes, hypertension and COPD. He had already a dislocated IOL in the vitreous cavity. So pars plana vitrectomy was done, and that dislocated IOL was removed, and scleral fixation IOL was done by the Cortex sutures, and after that the patient was discharged, and after 2 to 3 days the patient again presented with decreased vision. He had high Hema, almost you can say grade 3. And along with that, the patient also presented with vitreous hemorrhage. There was corneal edema, mild with dismissed folds. And but surprisingly, the intraocular pressure of that patient at presentation was not very high. This is the slit lamp photograph of the patient. Here you can see that there is high Hema over there. The AC is formed. But there is no view of anterior chamber. We cannot visualize the lens, anything, just there is high Hema which is dispersed, and at 6 and 7 o'clock we can also see some clotted blood over there. So this was dispersed bleeding over there, and it was a complication which developed after the surgery. This patient also had a history of using aspirin. You can also see there the clotted blood over there, which is shown over there at 6 to 8 o'clock, and along with that there is dispersed hemorrhage, high Hema. Basically the nasal view of that one, where you can see the hemorrhage, high Hema, along with the sutures which are applied over there to close the conjunctiva. So this was basically a scleral fixation IOL with Cortex sutures to secure the vision of the patient. The other view of the patient, here you can see the conjunctival congestion, vicral sutures and subconjunctival sutures can also be appreciated. Yes, this is another view. The inferior view, here we can again see the conjunctival congestion and mild high Hema, which can be appreciated in the partial view, which is over there. We can appreciate over there. Yes. The half view is being shown in this photograph. This is the superior part of the photograph. Again, bulbar conjunctival congestion, vicral sutures to close the peritomy, subconjunctival sutures can also be appreciated. So this is the superior photograph portion of the patient. So this is the UBM of the patient. Here you can see that there is the tense anterior chamber hemorrhage, high Hema over there, which is being shown. And in the medical report of this UBM report, they have also mentioned that even the posterior chamber, which is formed well over there, there is also hemorrhage over there. So both anterior and posterior chambers of the patient are filled with the blood. This is the B scan of the patient to rule out any retinal damage or retinal detachment or something. No, everything was normal. There was no retinal detachment, but there was vitreous hemorrhage over there along with the high Hema. So this patient developed high Hema as well as vitreous hemorrhage, and the retina was flat. There were no signs of infection, nothing like that. This is the OCT macula of the patient preoperatively. Here it shows that there is no macular edema, no macular lesion, everything is perfect. Just there can be seen that there is partial PVD over there. Otherwise, everything is normal. So the most important thing in these patients when they present to us is that intraocular pressure. We have to see how much it is high and for how many days, because high intraocular pressure can cause central retinal artery occlusion, central retinal vein occlusion. Apart from this, if hyphema is too much, it can cause corneal staining. There are chances of developing synecdoche. There are some statistics. For example, if the intraocular pressure is more than 60 for 2 days and more than 35 for 7 days, this is an indication for surgical management. If there is corneal staining, that can happen if the hyphema is more than half of the anterior chamber depth and the intraocular remains more than 25 for 6 days. Patient can develop corneal staining, and if the anterior chamber hyphema is more than 50% for 8 days, there are chances of developing synecdoche. So these 3 things usually we keep in mind when we are managing these patients. As I mentioned, we have already done his B scan to rule out retinal detachment. Now our focus is on visual acuity, intraocular pressure. Is there corneal staining or synecdoche formation? These are the most important things. And if these parameters are met, which I mentioned in this slide, we have to opt for the surgical management. Well, when we talk about the conservative management of these patients, the most important thing is bed rest, and patient should be encouraged to lay down in 45-degree angle. The reason is, in this position the blood sediments down and there is less chances of developing corneal staining and trabecular meshwork blockage. So this is the most important thing. The eye is covered with plastic shield. We have to control the intraocular pressure. We have to regularly manage the patient, measure the intraocular pressure. If patient has poor compliance, he is not going to use medicines. These patients can even be admitted. And we can use beta blockers, we can use alpha agonists to control the intraocular pressure, and Diamox, acetazolamide, even sometimes IV mannitol can be used if it is too high. And but epreclonidine is not used in sickle cell anemia, and these acetazolamide and mannitol should be avoided in sickle cell patients. So the thing is to control the intraocular pressure. The second thing is we have to control the inflammation, and these patients usually need aggressive topical steroids. Yes, we can use prednisolone acetate quite frequently to control it, the inflammation going overall. And the most important thing along with this, use of the cycloplegics. The cycloplegics basically, as I mentioned, that they prevent the formation of synecdoche, they maintain blood-aqueous barrier, and if there is any pain, the pain is also relieved because they break the spasm. So cycloplegics can also be used. Talk about the grades of hyphema. They may be graded from grade 1 to grade 4. Grade 4 is usually total blood in anterior chamber, and that's called the 8-ball hyphema because there's all around blood over there, and because of poor circulation of aqueous and deoxygenated blood over there, it attains the shape of black over there, and this is very prone to develop the secondary angle closure glaucoma and high intraocular pressures. If less than this is grade 3, and grade 3 we can say from more than half of the anterior chamber to 1/3, that is the grade 3, and less than grade 2 is less than half. So these are different grades of the hyphemas, and studies have been conducted to find out that as the grades of the hyphema increases, the chances of developing complications also keep on increasing. Yes, especially from grade 3 onwards, patient is prone to many complications. So this is very important, the grading system. If a patient comes to us, we should grade it properly. And what is the grade of the hyphema over there? I mentioned earlier, the main complications are that increased intraocular pressure, which can cause retinal vascular occlusions. Apart from this, there may be trabecular meshwork blockage and anterior synecdoche, posterior synecdoche formation. Pupillary block glaucoma can happen in such situations when there is blood in anterior chamber as well as posterior chamber fully filled. The possible of pupillary block is also very high. And the most important thing to be kept in mind in the management is that there are very high chances of rebleeding in these patients. Yes, rebleeding is also very much possible in the patients. So whenever we are going to, for example, we are going for the management surgical, so this thing should also be kept in the mind. We decide about the surgical management. We can do it irrigation and aspiration. We can use vitrectomy cutter for hyphectomy, and clot expression can be done. All these things can be done depending on the condition and situation and available resources available with the surgeon. If there is chances of developing a pupillary block, then the surgeon may also consider peripheral iridectomy. So these are the things are over there which can be tried and anticipated. But as I mentioned, these patients are very prone to develop rebleeding, especially if the grades are high. Staging grade wise, it is high, high Hema, they have chances of rebleeding. Trabeculectomy is usually not done initially, not very much common, but a few physicians and surgeons do try it, considering that. But otherwise, just anterior chamber washout and irrigation aspiration, that is usually sufficient to control the situation over there. We talk about the vitreous hemorrhage. Usually this vitreous hemorrhage and the RBCs settle down with the passage of time, and there is very minimal inflammatory response in the adnexal structures because of this hemorrhage over there. The studies conducted by Sanders and et al. Showed us that there is 1% per day resolving of the vitreous hemorrhage. So with the passage of time, as the RBCs settle down, this hemorrhage, fresh hemorrhage, keeps on changing the color. So the most important thing is we have to keep an eye on the retina. If we cannot see, we can use B scans regularly to see the retinal integrity. This was a case which I wanted to discuss with my respected audience, that a possible complication with scleral fixation IOLs when we are using Gore-Tex sutures, and these sutures passing through the uveal tissue can cause the bleeding, and this can happen. This should be anticipated by any surgeon who is going for surgery, especially in the patients who have some bleeding problems, who have coagulation profile abnormalities. These things should be addressed before the surgery. And along with this, other techniques which can also be attempted with this Gore-Tex suture technique is the Yemeni technique. That can also be attempted. But these are possible complications, and these are manageable by the conservative and surgical, and usually the results are quite good. I hope this presentation will be beneficial for my respected audience in their clinical practice. I want to thank you for your attendance and attention. Thank you.